practice hands-on palliative nursing. To conduct this, we again welcome Lieutenant Mrs. Alice Stella Virginia for the session.
So good afternoon. എന്തായിരുന്നു ഉച്ചയ്ക്ക് കഴിച്ച് ഫ്രൈ ആയി പോവോ ആവോ ഫ്രൈ ആവോ ഉറക്കം വരുമോന്നാ ചോദ്യം ഓക്കെ How many of you have seen pressure injury? Pressure injury. Only one person. Two. Most of which stage? Every stage you have seen. Okay. So you can see this is a video. Play cheyda.
Lots of taking.
A patient is not knowing, he doesn't have much sensation. So that is why we are able to put the finger. This was actually sent to me from one of my friend. His father was admitted. He was in fact in air mattress. Okay. After being in an air mattress, this is what has happened to the patient. Okay. Actually, I think a whole our finger, even the 2-3 fingers can go inside. How much deep it was. Okay. So I'll be just talking some tips how to prevent pressure ulcers and how you can help the patients and the family also. So before that, let us just have a look in palliative care what we do for a bedridden patient. So we say all the professionals should have a basic nursing skills, individualized planning, and we should remember the patient is going through difficult times and always see that the patient and the family is involved in all these things. Very important is communication skills, basic communication, basic care of the patient, assessment of the symptoms is very much. This all we have gone through yesterday. And of course, once in a month. So whenever I take classes for the qualified nurses who are working, I do tell them that once in a month you should gather all your nurses together, find out what are the problems they are facing in their wards. Okay, so that we can rectify the problems and we can have a smooth running. Okay, that is one thing. And one more thing is what it is. When we are constantly working in the same ward, especially ICUs, critical care and other things, what happens is we get exhausted. Multiple deaths will be the same in palliative care also. In a day you can see multiple deaths and all. Some people, they get exhausted seeing that. That stress will be there. Okay, what we said, grief and all. Okay, so the ward in charge is the person who has to sit with these people, talk to them. So you just heard about self-care caregivers. There should be a self-care for ourselves also. We need to take care of our body also. Okay, so that is also important. So you know the problems of a bedridden patient. These are the problems that we usually come across with the bedridden patients. So one is oral care, very important, oral care. Any patients 2 to 4 thali, we need to give a oral care. But when we give oral care also, remember, there are two things for the oral care. Especially when the patient is back home, whatever is available in hand, try to use it. So usually we say not to buy anything commercially from the, from the hospitals or from the pharmacy. Like some mouthwashes are available. Okay, that itself we can make. Like we say for the patient, you can use normal saline is very good for mouthwash. We use soda bicarb. We use lemon. These things, and we can improve for the patients who cannot use brush and paste. Okay. Now, routine mouth care is very important for other than other patients. 12 hourly we can give routine mouth care. Okay. Now one more thing, local, I will skip this one now. Proper positioning of the patient. If it is a patient who is unconscious, try to give that patient mouth care always on a side lying position, never on a, and you have to teach the family member also. Please don't put the patient in a supine position and give a mouth care. It should be always on a side lying position. Why? Otherwise they will aspirate. So that is a very important. And if possible, teach the family member how to give a mouth care. Using a brush, otherwise not using a brush also, how you can give a mouth care. Okay, using a brush, usually what we say, that is assisting the patient. I'll show you a photo here. See, oral care, conscious patient. Just you need to assist the patient. Give all the things to the patients and near the bedside. Patient will do it. Only you have to stand next to the patient. Okay. But when it comes to a patient who is unconscious, you are not able to get up, so we have to put the patient on a side-lying position and give a mouth care. Okay. Now, if the patient is unconscious, we need to teach the family member how to give a mouth care to an unconscious patient also. Usually we have mouth gag and all to open the mouth. Nowadays in the market, things are available with which we can open the mouth very easily. Okay, very soft, very soft mouth gags are coming, through which we can just keep it on one side, open it so that mouth will open, so we can give easily the mouth care. So these things we do. Otherwise what happens, oral care will be very poor, they will come with multiple problems. Okay. Now, we all know, you all must have seen patients with Ryle's tube. Yeah? See. Positioning for a Ryle's tube patient, whether the patient is conscious or unconscious, see that the patient is put in a semi-Fowler's, otherwise a Fowler's position. Otherwise they are going to aspirate. Okay. Then, you all know we have to pinch the tube so that there won't be any air entry. Then give the feeds. Okay. So, in a normal patient, 200 to 250 ml of feeds we can give to a patient. That also 2 seconds hourly. Okay. That we need to see the condition of the patient also. In some patients, there will be restrictions, so we have to reduce it. But a patient who is only in Ryle's tube feeding, NGT feeding, at least 2.5 to 3 liters of fluid has to go to the patient's body. Otherwise, what happens? Such patients will end up with urinary tract infection. Okay. I'm not going to teach you how to give it because you people know how to give it. But some important tips is that after giving the feed, see that the patient is in the same position for at least for half an hour. After that, put the patient on a side-lying position. Flat, but on a side-lying position. Why? Even if suppose the patient vomits out, what happens? It will drool out. The patient is lying on a supine position, what happens? The patient will aspirate it. We have come across cases. I have come across cases in my career. Patients, after sending home, aspirated and landed with aspiration pneumonia and even death also. So this you need to give a clear instruction to the family members. Okay. Now, Before giving feed, we'll be giving some water and then we give the feed. So total it should be 200 to 250 ml of feed, total. Okay. Now another thing is what we can give. Don't write and give protein powder and ensure and all for the patient. Whatever we are making at home, that all the things we can make it just like a soup or a juice, whatever it is, we can make and give to the patient. When we make dal, Pushpagiri nu parayunnalle, that water itself is full of protein. We can give to the patients. Take all the vegetables, boil it, mash it, take out the juice, give to the patient. That's a soup. So you can see clear tea we can give, weak black coffee we can give, clear soups we can give, strained fruit juices we can give, milk and egg flips we can give, thin custard we can give. And even main thing is salt. Unless until it is restricted, try to give salt at least in 3 feeds. Most of our patients land up in the casualty because of hyponatremia. Because they don't add salt in their food. And the patients land up here. They won't be knowing it is hyponatremia. They come and they say, patient is talking, irrelevant talk is there, disoriented is there, and they come and land up. It's not just because salt is not added to their food. So you have to teach the family member, at least in 3 feeds you have to put little bit of salt so that they won't land up with hyponatremia. Clear? Securing the tube, very important. Previously what they do is they secure it here on the forehead. No, please secure it on the side. It should not come on the patient's way. And when you secure it also, see that it is stuck properly. The tubing should not move up and down. Okay. And of course, tell the family member, anytime the tube has come little outside, do not reinsert. They have to go to a hospital. Patients do land up with all the rails tube coiled inside the throat. Family won't know, they will give the feed, patient will start coughing. Okay, so if the rails tube has come out a little bit also, not to reinsert. They can come to the hospital. These are the ways we have to do it. Okay. Now, another for in the bedridden patient, very important is perineal care. Perineal care is very important in bedridden patients because 24 hours they are lying down, right? So, cleaning the area is very important, especially if the patient is in an indwelling catheter and patient is having incontinence of bowel and urine, anything for that matter. Okay. Now, when we talk about the bowel movement for the patients, bowel care, most of the bedridden patients have constipation. Why? Because they are not moving on the bed. They are just lying on, no mobility. Okay. So, in palliative care, we gave the patients this one. We write laxatives. Family member won't give laxatives. Why? They have to clean the patient. So they won't give the laxative. But of course, they will report to us saying the patient's abdominal discomfort is there, patient is not eating, patient is having nausea, vomiting. So when we go and see what it is, constipation. Okay. So, another thing is in many of the patients taking a lot of medications also, they will end up with constipation. Okay. So, normal pattern we have to teach them and we encourage the family member every day. If the patient is, you are able to move the patient out of the bed, just take the patient to the bathroom, make them sit there so that it will become a pattern. But suppose you cannot move out the patient from the bed to the bathroom, at least out of the bed, give a commode to them so that at least the patient will pass in the commode. Now the next one is, it is difficult for the patient. Patient is passing every 3rd day or something. Otherwise, patient is constipated. So in palliative care, it is very important to do a rectal examination, remove the hard stool, then only we will give the enema. Why? Because Without removing a hard stool, if you give an enema, the result will be very poor. Whatever is there in the front, only that motion will come out. Loading is still up. So in such patients, we need to remove the hard stool, then give a high up enema. Okay, so in all the palliative care setup, we do this thing. If you come to know the patient is having a constipation more than three days, after taking the laxative also, it is better to go for a enema. It's not that again you have to add a softener and wait for the result. Okay. 1 second. So you can see rectal examination, manual evacuation and high enema. Okay. Instead of diapers, you can use newspapers. Encourage in some of the mission hospitals and all, they encourage to use newspapers instead of diaper. You know, we can just cut a small piece of plastic, that polythene comes, no? Just make it in a rectangle shape, keep 2 or 3 layers of paper, just tie it as a nappy for the patient. What is the use of that? First, and one more thing is, the newspaper is very cheap, easily decomposing, okay. And if you use a diaper, we will die, diaper will never die. Usually I say that. You have seen, you burn it, you do anything, still the diaper will be in the same. So it's very difficult to destroy the diaper. Cost. It is very costly. Diaper is very costly. Okay. And in some place we have seen, they'll put the diaper, morning diaper, they will remove only in the night. By the time what happens? This will become wet. The skin will become soft and they will start having a crack. So they will land up with a pressure ulcer. So instead of diaper, we can use even newspapers. We can encourage the family member to. I have used for my dad. We have used only newspaper for our daddy. Okay, so that's also one of the way we can help. Oh, sorry, that's what. Actually, I'll just show it fast and skip it off. I told you yesterday that whatever things we are having in our hand, we need to use it. So there was a patient in a hospice. The patient's wish was see a rectum. She had a big wound which has come out. Okay. So only her wish was that she wanted to sit, take a good bath and go to the temple. But the problem was, whenever she's trying to sit, what happens? It starts touching the bed. So she started having very bad pain. So actually, the people, the doctors and the nurses who were working there, they were not knowing what to do for the patient. And they wondered. I talked to you about quality of life yesterday, remember? So they asked me, they called me, they're from Tamil Nadu. So the doctor called me and she told me, ma'am, like this is there and all. So I said, can you send me a photo of that? Because I would like to see. So they sent me a photo. I saw, yeah, it is too big. If the patient is sitting, it will touch and she will have a pain. So I told, first of all, you do one thing. Why don't you put a napkin, nappy tie? Maybe simple cloth also will be okay. And just keep a inside night, this one, sanitary pad. And then tie it. After that, I told them, get some cardboard box. Okay. Fold the cardboard box nicely and make it a round. Just like a tire round. Wrap it with some clothing and then a plastic that you can use for the patient. Because if the patient is sitting, the bottom won't touch this one, bed. Okay. Then I told them, one more thing what you can do is, you can go to the tire shop. Inside the tire there is a thing. What is it called? Tubing. That is also very good. Thankfully, they did it. But before that, what they did, I'll fast skip, just have a look. I'll fast skip because I just don't want to show. This is the condition of the patient. They bought this thing, but it was not useful. They bought it before they called me. Okay, and after that, see, what I asked them to do is, they bought the the tubing of the tire. They made the patient to sit. Patient had a bath, and the patient went to the temple. She celebrated her 25th wedding anniversary also, and then she passed away. See, whatever was available, we made the patient comfortable. She had a very nice day, and she passed. Her wish was fulfilled. That was the biggest thing. She wished to go to the temple, and she felt that she was dirty. She wants to take a bath and go. Okay, so same thing in many patients. This happens. We give sitz bath and all to some patient, but we never find when hemorrhoids and all is there. When it comes out, the patients find it very difficult to sit. Okay, so we can improve. See, we have that air cushion, but air cushion, you know, it's only this much. Even if you put air inside, it won't bloat up too much. And if you try to sit also, what happens? The center round is not so big. So what happens, if you try to sit again, it is going to touch your bottom, perineal area. Patient will have pain. So we need to innovate new things, whatever resources is there, and apply it for the patient. Okay? And one more thing, here you can see, whenever a patient is given a commode, I mean Western commode to use, see that one stool is kept in the front. In a normal position, what happens is, patient won't be able to pass motion properly. Because why? I hope you can see this. You look at here. What happens to the rectum? It gets skinked. So what happens? The motion won't come out. But if the patient is sitting in a squatting position with a stool in the front, it opens. So patient will have a normal bowel movement. Even people who are elderly at home, those who use Western commode, we have to try giving them a small stool in front so that they will have a proper bowel movement. Okay? So these things are available in the market, very cheap, not so. This we can keep it on the top of the this one, Indian toilet, so they can sit. And this was one which one of our doctors, pediatrician madam is there. She developed this actually. She collected the old, chairs and gave to the industry to make a hole in that, and where we can keep this bucket. Here what happens is, see, if you use a commode, you must have seen a commode where the patients are being used. It's just like a stool only. So if the patient is sitting, someone has to hold the patient from the back. But here what happens? Patient can nicely sit, no need of holding, no need of support also. Okay, so this was developed by one of our madam. Now bladder care. Anytime any patient coming to you with retention of urine, okay, we have to be very careful to see what is the cause. Retention of urine can be caused even with constipation. Okay, we have drained 1,500 ml of urine from this patient. Actually, the patient didn't come to us because of retention of urine. Patient came to us with delirium. Patient was disoriented, irrelevant talk, trying to beat everyone, running and all. Patient has become delirious. One of the causes for delirious is also retention of urine and constipation also. So here what happened was, when the patient had come, family said, since last night the patient is very gone case, they said. So we made an examination from head to foot. While going, we found out bladder was full. And on top of that, patient has not passed motion for almost 1 week. We just put a simple catheter, drained out the urine, did a enema for the patient. Patient was fine. So this is another problem. So one thing is, in bedridden patient, before putting a indwelling catheter, try to find out make the patient to go normal, make that patterns so that the patient will have a normal voiding. until unless the patient is having an incontinence where the family cannot manage, we can put an indwelling catheter. Even for some patients, we ask the family member if they are able to give a bedpan or a urinal in a scheduled time. Unnecessary putting a catheter, we can restrict or we can stop. Okay. Then old age people. Suppose nowadays only old age people are at home. So one person is bedridden, the other person is also old. What they will do? In that case, of course, we can put a indwelling catheter, because indwelling catheter causes most of the UTI. You take one of the causes, indwelling catheter itself. Because many times, if there is no proper cleaning and all, there will be infection. So we try to prevent UTI. We can ask the patient's family whether they can take it without putting an indwelling catheter. This all is the same things. I just went off. Very important is the health education for the people who are in indwelling catheter. Okay. As I told you before, if the patient is just need to take at least 2.5 liters of fluid to prevent UTI. Next thing is always the bag should be below the waist level. It should never be above the waist level. Again, it will cause infection. You must have seen some patients walking in the corridor. Kanditilla, a bag ingane pokki pidichondu nadakkunnathu, that has to be avoided. You need to tell them always it should be below the waist level. On the bed also, it should be always below the waist level. It should never be on the bed. Okay. Then is the cleaning. If they are taking daily bath, well and good, because then they are going to clean it. If not, from the umbilicus to the mid-thigh, thorough cleaning should be there with soap and water. This we teach the family members. Okay. These are the main things that is very important. Teach them not to separate the uro bag and the catheter. Some people, what they do, they empty the uro bag, they will detach and they will go out to do it. Not to do that, because again it causes infection. Okay. See, this is the way it should be. See, below. Here also below. And this is called a leg bag. I don't know whether you people, anyone has seen leg bag? No. Leg bag is very good, because with the leg bag what happens, especially male patients and all, they can wear their pants because it's attached to the leg. We went to Tirupati, we met a patient over there who has undergone a nephrosis, both the sides. So he has 2 bags. Okay. So he was saying that he cannot go to the temple because he has to hold the bag like this and go. So we informed their family member, these bags are available and they can use it. So within 2 days, I think they bought and gave that bag. So he was very happy because he used to wear dhoti. So he tied it on this one and he went to the temple. But no one is going to see what you are wearing. See, things are there which we can modify. Ask the family. This is available and it's not very costly also. See, this is how you have to show. When you're doing anything you are teaching the family member, just show them also. Okay, some of the patient is with that, just go tell them, see, this has to be not to be detached. At least they will keep in mind. Yeah, now, this is very important. At the bedside of the patient, always, especially I tell, if the patient is at home, in a home setting, one calendar should be always there for the patient. Why? The patient needs to know which month and the date. Second thing is a clock. They don't need to know the time. Third thing is the newspaper and books. If the patient is fond of reading, give them. See, in COVID time, after my retirement, I know very well, because I got retired during COVID time. Till that day, what happens? Morning, I come afternoon at home, so I know the timing and everything. During COVID time, what happened? I used to think today is Thursday, today is Wednesday. Huh? I forgot the dates, anything. Because usually nowadays nobody keeps a calendar at home, right? Okay. Just think of a patient who is 24 hours in just in a inside of four walls. You won't be knowing whether it is day, whether it is night, which month. Okay. So these things has to be available in a patient's room. Torch. You may think, why the patient needs torch? Patient needs a torch at the bedside. We say dim light can be kept and a torch. Suppose the patient wants to get up and see something, keep a small torch to the bedside. Calling bell, very important. Because at times, sometimes even in our sleep, if we want to call them, sound won't come outside. But at least if a calling bell is there, we can ring the bell. Maximum I tell, keep a steel glass and one spoon also. You can do tan, 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 tan. They will come to know. So that is one more thing. Okay. Medications written in a bold letters. Some patients are able to take their medication, write in a bold letter and put it. Bottle of water, glass. Many of the patients, they can drink water. But nothing is available next to the patient's bed. Keep so that they will take it. And of course a wheelchair. Patients who are able to move out of. In palliative care, many of the patients, they know how to move from the bed to the wheelchair, from wheelchair to the bed. They get trained well like that. Keep a wheelchair next to the bed. Whenever the patient is feeling that I have to move out, the patient will move out. Okay. Now, we will come to the bed patients. Most problem is joint problem because they are in the bed, no exercise, nothing given. Patient will have contractures. So let us see what the patient can be done. As a tips, I will tell you, first and foremost thing to prevent a pressure ulcer. Any patient on a bed, bedridden, put the patient's bed always on the window side. Not to touch the wall, but near to the, why? If the patient wants to move, patient can hold the rails of the bed and turn. That is very important. Okay, one side they can put a rail or put a bar and tie it and give so that the patient will have two sides. Okay. The second thing, why you want to put the patient on the window side? Patient can have a look out. He will feel better. There will be good ventilation. So we need to encourage the family member to do it. Otherwise the patient will be stuck up. Patient cannot move. I remember a patient told me, so he did that. They have put in the center. Nothing is there for the patient to hold. So if they want to turn means we need to put something so that the patient can just hold it. See, affordable people, they can buy that bed. Okay, with the rails. People who don't have any money, what they will do? So we need to modify something and do it for them. Let us see now. Once again. I want to go, yeah, skincare. You all know bathing is very important, okay? But one important thing is, teach them when they are applying the soap, not to apply too much of soap for the patients. I don't know, I have come across people using Chandriga soap, Medimix, and one more thing is there, na? Chandriga, Medimix, I forgot. Hammam. This soap ഉപയോഗിക്കുന്ന ആൾക്കാർ soap ഇട്ടിട്ട് പുറത്തേക്ക് വരുമ്പോൾ നല്ല മണാ. Because നല്ലോണം അവരുടെ വിചാരം എന്താണെന്നറിയോ, നല്ലോണം soap ഇട്ടാൽ നല്ലോണം വെളുക്കുന്ന. It's not going to happen. Okay, that's what I do say. The thing is, they apply so much of soap that most of our pores are being closed. The sebum won't come out. Skin becomes dry. So for the patients and even for us, I'm talking about you also, take the soap always on your palm. Apply soap on your palm, then only apply it on your body. Even for the patients, you need to teach the family member not to apply the soap directly to the patient's body. It's going to make very dry and there will be a skin erosion. thorough cleaning should be there. Soap should not be there in the body. And teach them how to give a sponge bath. You ask our patients, no? നമ്മൾ ചോദിക്കും കുളിപ്പിച്ചോ എന്ന് പറയുമ്പോൾ അവർ പറയും ഇല്ല സ്പഞ്ച് ബാത്ത് കൊടുത്തു എന്ന് പറയും. മീൻസ് ആൻഡ് യു നോ ഹൗ ദേ ഗിവ് ദ സ്പഞ്ച് ബാത്ത്? ഐ വിൽ ടെൽ യു. ഒരു ബക്കറ്റ് വെള്ളം എടുക്കും, ഒരു ടവൽ എടുക്കും, അതിൻ്റെ അകത്ത് മുക്കും, അത് പിഴിയും, അതായത് മുക്കി തുടയ്ക്കുക. അതാണ് സ്പഞ്ച്. ഡെയിലി ചെയ്യുന്ന പരിപാടിയാണ്. ദാറ്റ് ഈസ് നോട്ട് എ സ്പഞ്ച് ബാത്ത്. Sponge bath, we need basin, we need water, we need bucket, we need sponge clothes. Lovely miss avada poyilla alla. We have faced it in army. 3 basins we have to keep. 2 buckets, 1 bucket for good water, 1 bucket for bad water, hot water, cold water, 3 sponge cloths. Adu kuda anda towel. This is how we learn sponge bath. And it will be just like giving a bath for a patient. We need to teach at least how to give a sponge bath to a patient. If they are not able to take the patient to the washroom, bathroom. Okay. So teach them how to give a bath. That is called like say bath, complete bed bath, partial bed bath and self bath. Anything can happen. Okay. Now, these are the common sites where you will get a pressure injury. See, you must be thinking why I'm talking always about army. Army is very strict. Okay. We used to get only weekly off is there when we have student period. Once we pass our student period, we will have how many off are there, only that we will get. That also will cut off. Why you know? Suppose we 4 are working together, you think. If a patient is a bedridden, okay, tutors will come and turn the patient and see if there is any redness. Suppose the patient has one little redness, also our off is cut. Mouth, if it is smelling, off is cut. It's very strict. So we have gone through that strictness. Because it is our fault the patient is. It is, if you go to the older nursing books, it is clearly written. Pressure injury, mouth ulcers, means mouth care. If there is any negligence, it is just because of the nurses only. Because we don't train the patient, they will have a pressure injury. Mouth problem also same. Oral care is very important in a bedridden patient. Okay. So that is why I'm saying we need to teach. So these are the, we can see the elbow in between the knees. If the patient is on a supine position, back of the head and neck, shoulder, lower back and the buttocks and the heel. The second one, this is where it will be on a side lying position, you see. This all you can put, so you are very good at art. Put some of this one, these things near your, get a permission and put it near the wards. So the patient will come to know. Family will learn about it. This is where they will have on a side lying position. On a prone position, these are the points, pressure points. And in a sitting position, these are the pressure points. Okay, now you tell me, in a lying down position, when we have to shift the position? 2 hours. And in a sitting position? In a paraplegia patient and all? Every half an hour, patient should relieve the pressure. Clear? Okay? Okay. Now, everyone has to answer. There are some special areas where we have to give attention when we are giving bath to a bedridden patient, normal patient also, even our body also. Mansilaya? Some places there are special attention kodukanda cheri areas under when we are taking bath. Otherwise, while giving bath. So just let me know which are the areas. അറിയുന്നവർ പറ. This side. Which are the areas prone to get infection and accumulation. Eyes, okay. Mouth access, no. Any other thing? Eyes where? Inner, any other than that? Okay, we'll come to. Any other place? Perineal area, okay. Special attention where we have to give. Boys? Nails, usually we do it. Inner thighs, that is the groin. Good. Anywhere? Under the breast. Behind the ears. I'll show you. See, they got it. Back of the ears and the upper fold of the ear. Neck region in obese patient. Axilla, that is your armpit. Elbow joints. Folds of the breast. Umbilicus. Groin. Folds of the buttocks. Back of the knee. And in between the digits, that's the finger and the toes and the ankles. Now we'll just have a look on that. Eye. See, when you open your eyes, this area where dirt accumulates. I agree with this one, but this is also an area where dirt accumulates. That's why we need to wash it properly. Now the second, nose. You know this area of the nose? കുറേ പേർക്ക് പിമ്പിൾസ് കിട്ടുന്നത് ഇവിടെ ചെറിയ ചെറിയ സ്മോൾ. ഓക്കെ വൈ യു നോ നമ്മൾ വെള്ളം എടുക്കുമ്പോൾ ഇങ്ങനെയല്ല വാഷ് ചെയ്യുന്നത്. പലരും ഇങ്ങനെ വാഷ് ചെയ്യാൻ മറക്കും. The dirt accumulates there, so small pimples will come over there. Okay, now that is the second place. Now the third place, ear. One is this part. Inside this and this part. Second is back of the ear. You know when we pour water, shampoo once we pour water, what happens? The water goes. But here it won't touch because it's little dip. So what happens? That soap, everything gets accumulated there. After some time, if you keep your hand, you will get it. Okay. Some people, they won't remember also after they'll start scratching. Okay. And after cherry skin idavu. Other is ear. Same inside. I don't say inside the ear. Just this portion itself. Some people who are walking next to you or sitting next to you, if you see, you can see how dirty it is. These are the places, hidden places where dirt accumulates. Okay. Now hand. Nails, we have to cut it. I appreciate it. But in between the nails, in between the digits of the toe and the fingers, it is very important. Okay. And that is why give a bowl of water to the patient, let them wash their hands properly. We tell give a bowl of water for the patient to immerse their toes into that, feet into that, and let them wash it. നമ്മുടെ കുളി കഴിഞ്ഞ് പണ്ടത്തെ ആൾക്കാരൊക്കെ കുളി കഴിഞ്ഞ് ഈവൻ ബാത്റൂമിൽ നിന്ന് പുറത്തിറങ്ങുമ്പോഴും കാലൊന്നും കഴുകിയിട്ട് കയറുള്ളൂ. Even if they come out from, they will wash their legs. You can have a test also. Most of us, all of us, we take a very good bath. നമ്മൾ ബാത്റൂമിൽ നിന്ന് ഇറങ്ങിയും വരും. കുറച്ച് നേരം കഴിഞ്ഞ് you sit and see in between the feet, digits, our toe, പൊടി ഉണ്ടാവും. Because all the water goes and ends up here. ശരിക്കും we need to put our finger and clean in between each digit. Okay, so this is also very important. And the second thing is, crack. Heel crack avla. And bedridden patients, it will be very hard for them. Okay, that will become like a crust. So you can help them out. Take little water, lukewarm water. Put little bit of shampoo or even salt also they can use. Shampoo little bit. Immerse the leg, feet for about 10 to 15 minutes. Wait for that. After that, your toothbrush is there. Use toothbrush. Just take it, slowly clean it because it will be very soft also. When a patient is having a very bad heel, you cannot use a normal brush. It will pain for them. So with the toothbrush, just clean it a bit. Remove, wash it nicely with water, apply Vaseline or oil. Okay, rest it. Daily you do it, you will see, find out that your heel will become just like um, newborn baby's heel. It will become very soft. We usually give the patients liquid paraffin to apply. Okay, so when you have crack and all, you can do this one. It clearly cleans and heals the heel. Okay, now umbilicus, that is the worst part of our body. All the water, all the oil, whatever it goes inside. Most of them, they won't clean the umbilicus. You know, children, what they do? You ask them to take bath. Their bathing is only this side. They will apply only soap here. And all the soap will go inside the umbilicus. That's all finished. So what happens after some time, if you clean it, whatever is coming, it will be in black color. So this is another place where we have to give attention. And the buttocks, in between the buttocks. The patients who are in diaper, what happens? Usually we'll ask the patient to put their legs, knees to fold it, and we used to clean it also. But what happens, when the patient passes motion or urine, the fluid, it tends to go this side and it will get dried up over here. Nobody will notice it properly. Once the patient starts developing a skin erosion, skin injury only, we will see what has happened. We have come across the patients like this. So it's very important to put the patient always on a side and then to clean it. So in between the buttocks is another place where they will develop skin injury. Underarms, that's another place. And of course the elbow. If many of the contracture patient, once it's contracted, this is a place where you will have this one, dirt will accumulate. Both, obese patient, this side also, this side. So if it is folds are here, we have to just extend the chin and clean it. And at the back, bend the chin and clean it. Now you see groins. And especially this one you see. See this area? We have to actually, if you push this one stomach, abdomen, if you see this side now, very dirty it will be. So in bedridden patients, these are the things we have to teach a family member. I have been to one of the hospitals where I found a patient, it was a cancer patient also, bedridden, very heavy, obese patient. You won't believe, she had a fold from here to here. I have still the picture with me. From here to here, she had 4 folds. And each fold, the skin has come out. It was reddish color and she was having more pain, the skin pain. Just because what? Nobody was trying to clean it properly. Okay, so that is the thing. Of course, under the breast and of course near back of this one, knees. Care of hair, please teach the family member how to give a patient head bath on a bed. They don't know, they struggle with that. And of course, we tell in palliative care, take the permission of the patient and you can cut off the hair also, make it short so that we can handle it easily. So we are coming to another thing, that is pressure. How many stages are there in a pressure ulcer? Sure? So she said 4 stages. Anything else? Four stages? 3 stages? How many stages are there? Confirm. What? ഉണ്ടാവില്ല എങ്ങനത്തെ Okay. So we have 5 stages. Now it has gone to 6 also. 5th stage is the unstageable. Okay, what is the first stage? Forget, your tutors are not here. Don't look at them. Now come on. What is the first stage? I can pinpoint and ask. Then it will become very bad. So better whoever knows, they can shout out. What's the first stage? There are tutors every day. ഇവർക്ക് ഒരു എക്സാം ഇട്ട് കൊടുക്കണം. പ്രഷർ അൾസറിൻ്റെ തന്നെ സ്റ്റേജസ് എഴുതാൻ. If I happen to be your examiner for Viva, I won't go and ask any other thing. I will ask only these questions. What's the first stage? Redness. Good. First we will find just the skin color change is there. What is the second stage? Yeah, skin integrity has gone. It could be epidermis or a dermis. What is the third stage? Subcutaneous tissue. Up to that. Fourth stage? Deep, including the muscles and... So what is unstageable then? Mole? Mole okay ആയിരിക്കുമോ? അല്ല. Unstageable എന്താണ് സംഭവിക്കുക? What happened? Bones comes in the 4th stage. 5th stage, it will be eschar. Eschar will be there. Okay. So it becomes very difficult to know what is happening inside. Okay, we will come to that. So I am not going into the causes and all. Lot of causes are there for pressure injury. And remember, it is not a bed sore now. It is not a pressure. Don't say it's a bed sore. It's a pressure injury, otherwise pressure ulcer. Okay. Now, the main thing is, whatever normal causes we have seen, apart from that, some other things are there. Why this happens? Okay. It is just because of the negligence of the patient, family, and our negligence also. So that is what we have to teach the family member why a pressure injury is developed, otherwise developing. So how we can protect it. So yesterday I told you, first and foremost, teach the family member how to make a bed. Bed making is very important. The second thing is putting a patient somewhere near to a window, changing the position. And tell them, if you don't do it, the patient will land up with a pressure injury. That is important to teach them. Okay, so we will come to that. Just I am skipping all these things because you know these things. They will come at 3:30. They will come at 3:30. So this is the stage 1 where the skin is still intact, but there is a redness. Nothing to be done, just relieve the pressure. That is the important thing. But in a second stage, you can see there is a shallow ulcer is there. You need to just clean with a normal saline, put a dressing, relieve the pressure. Now when you come to the third stage, you can see it has reached up to the subcutaneous tissue. No infection, saline cleaning is okay. Clean it, put a dressing pad, relieve the pressure. Now this is the 4th stage. 3rd to the 4th stage also this one. Because you can see surrounding, it is just the sturge, but it has gone inside because you can see the center also. Okay. Now in such patients, I'll show you one more picture. Now you see this one. 4th stage, how it is. It's gone deep. There is a big hole as if. Okay. In these cases, packing the wound is very important. If you don't pack the wound, only the skin will close, but there will be a hollow inside. So packing the wound is very important. After cleaning, you have to pack the wound, but it should not be too tight also. Little loose, you have to pack the wound, then give a good dressing. Okay. Now the fifth unstageable will go. Now you see this one. This is unstageable. Can you just have a look at this? You see this portion? You see here? It's dark. There is a scar over there. Okay. Now, to remove that scar, sometimes it's very difficult also because it will be very hard. So what we do is usually we make some markings on that, apply some medications which will make that. Usually we apply vinegar, debrin, so a lot of things are there. We apply it on so that that eschar will become soft and then we can cut it. Once you remove that eschar, you will come to know how deep it is. That is why it is called unstageable. But of course, when the patients are in end of life care, we cannot do it also. Because there we focus only on the patient's end life, what are the problems we remove. But of course, we do the dressing. But no need of removing a slough over there. Okay. Eschar is not that, many of the patients, they don't say they are having pain when the eschar is there. So that is why we are able to cut it. But cutting also, we cannot just cut it off. If that big eschar is there, at one stretch I cannot cut it off. Bit by bit only I can cut because they will start bleeding. Okay. So on a small basis, maybe day by day or twice in a week, we have to slowly cut and remove it. Okay. Now you tell me, what are the 3 important things that will help a pressure injury to heal? Three things, important one, which will help the ulcer to heal. Diet, good. Nutrition is very important. Bedridden patients, usually their hemoglobin will be very low. If hemoglobin is low, what happens? It won't heal. So we need to see their hemoglobin also. Now second one, nutrition is okay. Then what she says? What are the 3 things that are important for a ulcer to heal, otherwise a wound to heal, not malignant one, I'm talking normal one. It comes everything in nutrition. Not back care. Dressing. Good dressing. And the third one, relieve the pressure. If you are not relieving the pressure, it will be the same. 3 things remember, relieving the pressure, nutrition and good dressing. Okay? There is a 5 pillow rule also. Pillow 1 under the leg, between the ankles, between the knees, and 1 at the back, and 5th one under the head. I'm not going into detail of these things. I think, yeah. Now this is very important. Nowadays we are getting overhead bars. Okay, so if the patient is on a lying position, patient can hold that bar and relieve the pressure. Side rails are there. See, side rails it can be available. Putting the patient on the bedside so that they can hold the rails and sit. This I told you. Back support, okay, that can be used. And if there is no back, if the patients are poor, we ask them, put the patient near the wall so that the patient can sit. Okay. Of course, waterbed and airbed. Remember one thing, even if they use a waterbed and airbed, patient's position has to be changed. Otherwise, they will develop this pressure injury. It's not that once in the bed means no need of changing. No, they need to change. Only the thing is not so frequently like how we do every 2 hours. Okay? Okay, so this is I don't know whether you all have seen this. I just love this one video. Just have a look. This is about an eagle, the rebirth of an eagle. So I hope you understood something out of that. Since yesterday, whatever videos I was showing, it all shows that there should be a change. We should have a good attitude. Okay. So just I want to talk to you about some malignant wounds, what we face during our, in my career, what I have seen. Malignant is one of the things, very bad when we see a patient with a big wound. It hurts very badly. And especially when the patient is having a head and neck cancers, otherwise a breast wound, somewhere in the femoral, some children coming with osteosarcoma, big wounds and all. Okay. And altogether when we see, always we have to keep in mind that the concept of the palliative care, physical, psychological, social, spiritual is very important. Okay. Why? Because some people they ask, I have never smoked, I have never used, I'm not an alcoholic, but why it came for me? And people who have done it, if a wound comes, they say, yeah, I have been chewing tobacco, that is why I'm having a wound. But when a patient who did not do anything like this, and he says there is a wound, we don't have an answer for him because he asks, I have never chewed a tobacco, then why this happened to me? In such patients, very difficult at times to answer them. And the second thing is, they become so stressed and tension. At times they become very depressed also. Okay. So now let us see what about the malignant wound. It can be a primary or a secondary malignant growth in the skin. Usually it's an ulcerated one. Common 5 to 10 patients with metastatic cancers. Breast, head and neck, back, trunk, abdomen, groin, axilla and genital. Now you see these patients, this wound. This was an actual patient for us. This patient had a very bad wound over here. She had kept it open when she had come to us. Means she has come to the college. It was kept open. And we could find maggots. So when we asked, why can't you cover it? She hesitated to cover it. But of course, we had to convince them that you have to keep that wound always covered. Okay. Now, just looking at that, tell me what could be the problems with a patient in such wounds? What are the main problems that comes when you see a patient with a wound? Normal physical problems, what it will be? Pain, wound discharge, foul smelling, anything? You told something. Body image, disturbed body image, that is psychological. Anything else in a wound, physical? Pain will be the foul smell is there, that is called malodor, what we say. Exudates can be there. Anything else? Itching, yeah, good. Itching. What about bleeding? Malignant wounds, it bleeds also. Bleeding is one of the problem, and that is another one is maggots. Have you seen maggots? Anyone? No one. Okay, if you see noodles, you will remember maggots also. Okay. So let us see. The issues with this necrosis, ulceration, and infection by the anaerobic and aerobic bacteria, and which leads to many issues. So when we come to the physical, psychological, social and spiritual. Now tell me, what can be the causes of pain? What causes pain in a wound? What can cause a pain in a wound? Wound itself can cause pain because of the nerve damage. Okay. But one main thing is there. You know what it is? The pain with what we give the patient. What pain we can give the patient? Dressing pain. You know, many of the patients, patients, when we come, ask them to do the dressing, they'll just come peep in the procedure room like this. Ayyo, ee sister anna venda, pinna varannu. They are very scared of the doctor and the sister who does a very bad dressing. Okay, so main cause is psychological trauma for a patient who has undergone a very bad dressing, okay, which caused them pain. They won't enter the procedure if that person is there. So we cause pain first, because the other pain we can remove, but the psychological pain is very difficult. Okay, first and foremost, remember, whenever a patient is coming with any type of wound, that means, I am not talking about a surgical wound, okay? See that the wound is well soaked, then only remove it. Without soaking, don't remove it. It's very painful. I usually say, once you soak it, if you remove, it should just come in your hand. You should not pull it up. That is the first and foremost thing. Second thing, if the patient is having pain in a malignant, usually we ask them whether you have taken your medications, pain medications. If not, give the medication, wait for the pain to reduce, then you can ask the patient to come for the dressing. Third thing, any incidental pain is there, we give medications for that. Incidental pain means like I'm moving on, that time I am getting pain, we have to give a medication. Okay? So pain, malodor, infection, bleeding, exudate, and infestation with the maggots. Psychological, someone told about the disturbed body image. Sexuality, fear of death. The wound starts becoming big. I will have a fear that I am going to die. Depression and anxiety, shame and isolation. Still, stigma is there in our world. Cancer means only the people who have done something wrong, they will get cancer. People think like that. Okay, so it's a shame for them that I got a cancer to tell. And isolation, they get isolated. Social, family isolation, social stigma. And this wound affects the family also, because if there is very bad smell, family and even the patient also, someday family will tell, he's not eating food because of the smell. We are also not able to eat because of that smell. Okay, so that becomes another problem. Effects on their sexual relationship and marital disharmony. Spiritual, the question comes, why me? I was very prayerful, still it happened to me. Some have the guilt saying that I have done something wrong in my life, that is why God has punished me. So a lot of questions can come from the patient, why this happened to me. More than a cancer, sometimes I felt when there is a wound, people become distressed. So palliation principles, palliation the symptoms, holistic care, physical, psychological, social and spiritual care. And of course, empowering the patient and the family to care the wound. I won't go into this surgery and all, you know it very well. So, when we talk about minimizing pain, deep pain, we have to ask the patient whether they have taken any medication. Superficial pain will be the local application of lignocaine or sensocaine, and incidental pain, we give ketamine. Now, malodor. Daily cleaning and dressing is very important. In palliative care, we use local metrogel. You know metrogel tablets, we powder it and that we use because it reduces smell very fast. So if first time when the patient comes, the smell will be very bad, malodor will be there. What we do is, we take metrogel solution is there, IV solution, we clean with that. Then we give a proper dressing with metrogel powder also. And within 2 days, you can see the difference. Because family will tell they started eating food and all smell has reduced. Okay, so that's why we use metrogel. We use only normal saline for cleaning, even for a pressure ulcer also. Okay, of course nowadays for pressure ulcer, people started using Debrin, many things have come out. Okay, but still in some places we still use metrogel. Infection, daily dressing is very important. We don't do slough cutting. Remember one thing, malignant wound, no slough cutting. Patient will bleed and die. We don't use betadine, we don't use hydrogen peroxide. Okay? Managing bleeding. Again, why bleeding? a malignant wound never, even in pressure ulcer also, never scrub the wound. Even if you pour normal saline, it is just mopping. Otherwise, they will start bleeding. Okay. So, apply local pressure if there is a bleeding. Then we apply sucralfate powder. Ethamslate tablets are there, trans tablets are there. But in palliative, what we get sucralfate tablets, plain. We powder it and we apply it. But again, in head and neck cancers, it's very difficult because head and neck cancers were, they are on the main vessel. At times, there will be a blowout. It becomes difficult. Once blowout, that's the end also sometimes. Okay. So, we do anticipate it and tell the family member also, if it's a head and neck cancers, to be very careful because any time this will open up. So that time they have to cover the wound with dark colored clothes, not with white cloth, so that we can mask the bleeding. Okay. Palliative radiotherapy is also good. Now you see this wound. Can you see the bleeding here? See? This will start slowly, slowly, and then it will open up. Okay. Now, maggots. How to remove the maggots? Physically you can remove. We apply turpentine oil to remove the maggots, but not. We dilute it and do it. 1:1 we dilute with the normal saline, and then we directly sprinkle it. Otherwise, spray it on the wound. Otherwise, soak it and keep it on the wound. Why, turpentine, if it is used apart from the wound, other than the wound ridge site, it will burn the skin. So, we have to do it directly on the wound. Can you see the? You see? And maggots also have they have a peculiar character. If you show the torch direct, they will go inside. So we have to show from the opposite side, we have to throw the light. Then only you can remove. So what we do is, we soak it, keep it on the wound for some time, like it's suffocation. What happens? After some time it starts coming out because they get suffocated, they come out. So pick it with the forceps and put it in a hot water. Okay. But we have to do at least 3 to 4 days continuous. So once we have removed, clean with normal saline, apply metrogyl, send the patient. Next, again the same thing with the turpentine. With turpentine dressing, never send a patient home because it is irritating. Now, I won't forget about this patient. This is from, I have been to Maharashtra for a training program. This patient was brought into our palliative ward. Is almost 65 plus something. They are a joint family. More than 50 people are there in their family, in one house. They have wrapped this fellow patient in one, bed sheet. Both the sons were carrying him, and while they were going, we can see such a big maggots falling down. You can see here, if you see that, they can see it very well. It's more visible over there. It's just like clusters it is. Okay. So, it was all over here. And when we open these lips like this now, you can see, and someone was running here and there. We managed to, because the patient was in a bad pain. We had to give morphine for the patient, to reduce the pain, and we immediately took some turpentine, nicely squeezed, and we kept it over here, and we started removing it out. I still remember I asked his wife was standing. I asked his wife just to help out to remove the shirt, what he was wearing. No? She said, ah? That's what how she showed. No? And I asked the son, when this happened? I think, yeah, then I asked them, no, kab se hua? I said, then he said, just yesterday only it's saying. Appa ഞാൻ palliative care ഒക്കെ മറന്നു പോയി അവിടെ. I lost my temper to say very badly. I said, how can you tell it's just started yesterday? Such a big maggots won't start. I have seen maggots starting. It will be just like a pinworm. അത്ര ചെറുതായിരിക്കും. Then slowly they become big if it is not properly taken care. Okay, this patient was just only for 3 days and he passed away. Okay, so negligence. Can you imagine 50 people in a house, they have not taken care of a patient. So this happens. So maggots is because of negligence. We say always 24 hours this should be always covered. It should not be kept open. No one can see when the flies is coming and sitting. We ask them to use mosquito net so that it will be covered. Okay. And this we will put in the hot water. So continuous 3 to 4 days you do what all the maggots comes out. Okay. So this we have to again, teach the family member, empower the family member, 24 hours this should be covered. You see these wounds. These are oral wounds. You see this side the patient, this one. Okay, so training of the carers is very important. It's a practice. We see that whenever we do the dressing, patient's bystander is next to us to teach them. And not only to teach them, they have to get adjusted to that. Okay, once they learn it, we can send the patient on discharge and we can make a follow-up during the home visits. Okay, how to make a saline? Because saline is also costly. So we ask them to put 2 teaspoons of salt in 1 liter of water, boil it, cool it, and to use it. And how to make the dressing materials? Cut normal cotton clothes are there, wash it nicely, dry it, cut the clothes, steam it. This one idli vessel, steam it, put it in a nice clean container, okay, and to use it. And every 3rd day they have to, they have to re-sterilize it. This is what they are using. People who are not financially stable, they can use it. Okay. This is okay. So I think I have covered. So, with this, we are completing our session. If you have any queries, you can ask.
Thank you, ma'am, for your words. As we come to the conclusion of this inspiring day, we now move on to the valedictory function. Let's stay together for the closing ceremony of this wonderful program. Now it's time for case study presentation. For presenting their patient, I invite Ms. Anne Maria for the presentation.
Good afternoon, all. Every patient's journey reminds us that behind the laboratory values and imaging reports lies a human story of courage and hope. Respected dignitaries and one and all who gathered here, it's my great privilege to present a clinical case that not only reflects the clinical challenges of advanced prostate carcinoma with bone metastasis but also highlights the importance of early diagnosis and evidence-based treatment and multidisciplinary care. So, the prostate carcinoma is one of the most common malignancies in men and major cause of cancer in that related to morbidity and mortality. And the bone is the most frequent site of metastasis, and the prostate carcinoma with bone metastasis is a late stage in which the systemic spread of cancer commonly to the pelvic bone, and it causes the fractures and pain. As a part of my clinical posting, I got assigned to the patient, Mr. X, 66 years old male patient, came to the oncology department of Pushpagiri Medical College Hospital with the chief complaints of severe back pain, pelvic bone pain, and generalized weakness. And it's also including urinary symptoms like hesitancy and noturia. And he also reports the occasional constipation. And there is no prior malignancies in his family. The progress of the disease is that the patient was initially complaints of persistent lower back pain and pelvic bone pain and generalized weakness and loss of appetite, and the clinical examination shows that the pallor is present, and it shows that the bony tenderness over the lumbar spine and pelvic, and on the digital rectal examinations it shows that there is prostate gland is enlarged and the prostate gland is hard and nodular. He had also undergone certain special investigations such as prostate specific antigen. It shows that 150 nanogram per milliliter, and it is also elevated, and alkaline phosphatase of the patient is also elevated, and it shows 192 international unit per liter, and it is also elevated. It shows that it's affected to the bone. And the prostate biopsy shows that there is an adenocarcinoma of the prostate gland, and in 2020 he had found that it had spread to the bone, and he is currently undergoing the cycle 7 of chemotherapy. The treatment of the patient was he had undergone the cycles of chemotherapy with injection doxycycline 75 mg, and he also underwent a bilateral orchidectomy on 3/6/2020 as a part of androgen deprivation therapy, and as a part of his pharmacological management includes bisphosphonates for bone protection, androgens and steroids, and supportive care also provided to the patient. The nursing diagnoses are acute pain related to bone metastasis as evidenced by verbalization. The patient reports of back pain and lower pelvic pain, and impaired urinary elimination related to the prostate enlargement as evidenced by urinary hesitancy and frequency. An imbalanced nutritional status less than the body requirement related to chemotherapy-induced anorexia and nausea as evidenced by verbalization. So the final condition of the patient is that initially the patient was response to chemotherapy and it shows that there is a pain is present and the PSA values of the patient is elevated. And after 12 months of it shows that the rising of PSA and there is a spread of bone pain to the regions. And so the patient was treated with second line therapies. It includes chemotherapy and mainly with injection doxycycline and the novel hormonal therapies. On regular follow-up, and it shows that the pain is reduced with radiation therapy and the steroids, and analgesics is were provided to the patient. So the conclusion, prostate carcinoma remains one of the most common malignancies in men, and the bone metastasis is the most frequent. In this case, the patient progressed from primary androgen deprivation therapy to second-line therapies to the natural cause of advanced disease. So, every case is not just a disease, but a story of resilience, science and care through evidence-based practice and compassionate nursing. We can transform its challenges into a ray of hope. Thank you.
Thank you, Anne Maria. That was an excellent presentation. Next, I would like to invite Ms. Jyotilakshmi to present the case.
So, good afternoon to all, respected dignitaries, teachers, and my dear friends. So, I'm very glad to have this privilege in front of this big conference to present my case presentation, carcinoma of stomach. So, moving to the introduction, carcinoma of stomach is one of the main type of malignant tumors, mainly arising from the epithelium of the epithelial lining of the stomach. It is one of the mainly adenocarcinoma. So, moving into the biographic data, as part of my clinical posting in Pushpagiri Medical College Hospital, I got assigned patient Mr. X, 46 years old male patient, presented with complaints such as abdominal pain, multiple episodes of vomiting, constipation and intestinal obstruction. Later, moving to the progress of the disease, the patient about 1 year ago at 2024, he had similar complaints such as abdominal pain, vomiting and intestinal obstruction, so that after certain investigations such as biopsy and imaging studies, the doctor diagnosed as carcinoma of stomach and had undergone 2 cycles of chemotherapy with cisplatin and also had undergone partial gastrectomy. Later, his condition got stable, and after 1 year, around 2025, he came with the same complaints along with intestinal obstruction, and after that, the doctor diagnosed it as metastasis and recurrence of carcinoma of stomach. So the doctor planned for an exploratory laparotomy and performed the procedure. Now the treatment modalities include treated with injection fragment, injection tramadol, injection fortwin and certain other medications mainly for pain management has been provided for the patient. So moving to the nursing diagnosis, acute pain related to surgical intervention as evidenced by verbalization, fluid volume deficit related to impaired emptying as evidenced by multiple episodes of vomiting, imbalanced nutritional status, less than body requirement to reduce to food intake as evidenced by reduced food intake. And I had provided a comprehensive care to the patient, mainly the pain management for the surgical intervention and diversion therapy, and it is essential for this patient to have a proper diet management, proper surgical wound dressing care and every. So the final condition of the patient, The patient had undergone exploratory laparotomy and had also got reduced food intake and other issues with that. But with a proper and efficient management, the patient condition got stable. So, moving to conclusion, I had provided a comprehensive care to this patient and the patient condition also got better. But about the carcinoma of stomach, it is one of the most malignant cancers. Due to late diagnosis and poor prognosis, it may cause more problems and become more and more difficult to treat. So, thank you one and all.
Thank you, Jyothalakshmi, for the splendid presentation.
ആണോ? പാട്ട് പാടാം. ഞാൻ പാട്ട് പാടി ഇനി പാടുമെന്നുള്ളതാ. അതല്ല, ഞാൻ പാടിയ ശേഷം. ഓക്കെ. Okay, so there is a challenge, okay? Ashwin told if I sing a song, he will sing a song. It's okay? My nose, everything is blocked and I'm not a good singer. And I will try to sing, okay? I'm not a good singer. Because I want him to sing. You have to sing next time. So I'll sing an old Hindi song because Malayalam, I know songs, but I must have forgotten all the wordings. Okay. Ashwin, ഇത് സൗണ്ട് ആക്കാൻ പറ്റുമോ? Ashwin will sing a song for us.
I'll sing a Hindi song, okay? It's a soothing song, not a joyful song, so just enjoy it. हौले से धीमे से मुझको बाहों में भर लो ना तुम, नर्म सी सांसों में मुझको आहों में भर लो ना तुम। सुन जरा मेरे पास आ, अब बैठे हैं हम भी यहाँ दिल के दरमियाँ। बारिशें हैं बारिशें तेरी ही बातों पे मैंने सजा ली है दुनिया यहाँ दिल के दरमियाँ। बारिशें हैं बारिशें अब तू आती है बुलाती है बिस्तर से यूं गिराती है कि सोऊं मैं बाहों में बस तेरी ही। जब बारिशें बरसती है पागल जैसे तिरकती है, तुम जैसी हो बस वैसे ही रहो। थैंक यू।
जान ये वार दूं, हर जीत भी हार दूं, कीमत हो कोई तुझे बेइंतहा प्यार दूं। मैं जान ये वार दूं, हर जीत भी हार दूं, कीमत हो कोई तुझे बेइंतहा प्यार दूं। सारी हदें मेरी आप मैंने तोड़ दी, देखकर मुझे पता आवारगी बन गए, हाँ हंसी बन गए, हाँ नमी बन गए। तुम मेरी आसमां मेरी ज़मीं।
As we come to the conclusion of this inspiring day, we now move on to the valedictory function. Let's stay together for the closing ceremony of this wonderful program.
To extend the warmth and official set, the tone for today's program, I would like to welcome Mrs. Delcy Matthew to deliver the welcome speech.
A very warm good afternoon to one and all. Over the past 2 days, we have gathered here to learn, share, and grow together. Today marks the conclusion of this enriching journey and also the beginning of many more to come. On behalf of the organizing committee, I take immense pleasure in welcoming Reverend Father Dr. Biju Verghese, CEO, Pushpagiri Medical College Hospital, Reverend Father Matthew Puttanpurail, Director, Pushpagiri College of Nursing, to this valedictory function in their absence. A hearty welcome to our Principal, Professor Vinita Jacob, Vice Principals, Mrs. Ranjini Devi, Sister Mary Jyoti OSS. We welcome you to this valedictory function. I would also like to welcome our distinguished speakers, Lieutenant Ms. Alice Stella Virginia, Lieutenant Colonel Lovely Anthony, Dr. P.T. Thambi, Ms. Anne Jomi, Ms. Anu Savio Telly for this valedictory function. A sincere welcome to all the faculty members, dignitaries, participants, and my dear students. Your presence has made this occasion truly meaningful. This valedictory function is not merely a closure, but a celebration of knowledge gained, bonds created, and inspiration ignited. Let us cherish the experiences we have gathered here and carry them forward into our professional and personal lives. Once again, I extend my warmest welcome to each and every one of you. Thank you so much.
Thank you, ma'am. Now, we take a moment to express our gratitude through presentation of memento. These are tokens of appreciation for the invaluable presence and contributions of our esteemed dignitaries. May I invite our beloved principal, Professor Mrs. Vinita Jacob, to present the memento. And to receive the memento, I invite Lieutenant Mrs. Alice Stella Virginia. Now, I would like to invite Lieutenant Colonel Mrs. Lovely Anthony to receive the memento.
Let's be real, most people over 40.
Thank you, ma'am.
Now, we move on to a special moment of presenting certificates to our respected delegates. These certificates are a token of appreciation for their valuable participation and contribution. We kindly invite our beloved Vice Principal in Academics, Professor Mrs. Ranjini Devi, to present the certificates, and I request a representative of St. Thomas Hospital, Chetipura, to please come forward to collect the certificates on behalf of other delegates who came from Chetipura. Any one representative from Chetipura, please come forward.
We kindly invite our beloved Vice Principal, Sister Mary Jyoti OSS, to present the certificate. And I request a representative of Pushpagiri Medical College Hospital to please come forward to collect the certificates. Any one representative.
Thank you, sister. Thank you, ma'am.
Now, I humbly invite Shwan and Sashaji to kindly share the valuable feedback with us.
Good afternoon, everybody. This is Shwanel Sashaji, and I'm standing here representing all the students and the participants. I would like to sincerely thank our esteemed speakers, Lieutenant Alice Stella Virginia and Colonel Lovely Anthony, for your very enriching two-day session. And these 2 days of conference was nothing but inspiring and very informative. Over the past 2 days, we have learned that the importance of skincare, proper skincare, the prevention of pressure ulcer, and the positive attitude of nurses that we provide will play a vital role in the caregiving. And also yesterday's afternoon session was very interactive and also very entertaining, because you have taught us about the bandaging and the exercises that we can provide to lymphedema patients. It's a boost for our practical skills, and I'm very sure that we can use it effectively for care that we provide to our patients, not just in the palliative ward, but every ward that we go. And no matter we are just student nurses, but the small actions that we provide, when we do it with lots of sincerity, and I'm very sure that these can improve the overall quality of care that we provide to the nurses. What really touched us the most in the past 2 days, when I've asked a few students for their feedback, is that we felt that both of you have spoken from your hearts, and this reminded us that palliative care is not just the medical interventions that we give, but it is doing what is right. And when we do it with dignity and empathy for the patients, it can really improve the quality of care that we provide, and especially patient-centered care. And so we are really grateful and thankful for your time, effort, and dedication in guiding us. And I also thank our principal ma'am and the management for initiating this conference, and our med-surgical department faculties, our HOD Sylvie ma'am, the members Maya ma'am, Sajida ma'am, Delcy ma'am, Mariamma ma'am, Sister Tessin and Jacqueline ma'am. Thank you all. All of your efforts are not gone unseen. We really appreciate your efforts and what you have done for us behind the screen. And I really thank you for introducing this wonderful team to us. It was really productive and really fruitful for all the participants who's come here. Thank you so much. Thank you.
Thank you, Shwan. May I kindly invite Ms. Beena Verghese from CNE Department of St. Thomas, Chetipura, to share her valuable feedback.
Good evening all. നമ്മളുടെ ഈ പുഷ്പഗിരി കോളേജ് ഓഫ് നഴ്സിംഗ് ഒരുക്കിയ പാലിയേറ്റീവ് കെയർ എന്ന പ്രോഗ്രാം വളരെ ഫ്രൂട്ട്ഫുൾ ആയിരുന്നു അല്ലേ? 2 ദിവസം പോയത് അറിഞ്ഞില്ല. പാലിയേറ്റീവ് കെയറിനെ പറ്റി അധികം നോളജ് ഉണ്ടായിരുന്നോ? ഇല്ല, അധികം ആരും സെലക്ട് ചെയ്യാത്തൊരു ടോപ്പിക്കായിരുന്നു ഇത്. നമ്മളുടെ ഈ വർഷത്തെ തീം തന്നെ അച്ചീവിങ് ദ പ്രോമിസ് യൂണിവേഴ്സൽ ആക്സസ് ടു പാലിയേറ്റീവ് കെയർ എന്നതാണ്. അപ്പോൾ അതിൻ്റെ ഒരു തുടക്കമായിട്ട് തന്നെ എല്ലാവരിലും ആക്സസ് എത്തിക്കുക, പാലിയേറ്റീവ് കെയർ എങ്ങനെയാണ്, എന്താണ് അത് ചെയ്യേണ്ടത് എന്നുള്ള ഒരു നോളജ്, ഒരു അവയർനെസ് ഈ 2 ഡേയ്സ് കൊണ്ട് നമ്മൾക്ക് പുഷ്പഗിരി കോളേജ് ഓഫ് നഴ്സിംഗ് ഒരുക്കി തന്നു. അതുപോലെ തന്നെ സ്റ്റെല്ലമ്മ പറഞ്ഞ നമ്മുടെ ഫസ്റ്റ് ക്ലാസ് എൻഹാൻസിങ് ദ ക്വാളിറ്റി ഓഫ് ലൈഫ് ത്രൂ കമ്പാഷനേറ്റ് കെയർ. അപ്പോൾ പാലിയേറ്റീവ് കെയർ എന്താണെന്ന് മനസ്സിലായല്ലേ? മനസ്സിലായോ? ഇറ്റ്സ് എ സ്പെഷ്യലൈസ്ഡ് അപ്രോച്ച്, മെഡിക്കൽ അപ്രോച്ച് ആണ്. അതുപോലെ തന്നെ ഒരു സീരിയസ് ഇൽനെസ് ഉള്ള, ലൈഫ് ത്രെറ്റനിങ് ഇൽനെസ് ഉള്ള ആൾക്കാർക്ക് എങ്ങനെയാണ് അവരുടെ സിംറ്റം മാനേജ് ചെയ്യേണ്ടത്, എങ്ങനെയാണ് അവരെ അപ്രോച്ച് ചെയ്യേണ്ടത്, ആക്സസ് ചെയ്യേണ്ടത് എന്നുള്ള കാര്യങ്ങൾ നമ്മൾക്ക് മനസ്സിലായി. അതുപോലെ തന്നെ അതിൻ്റെ ആസ്പെക്ട്സ് എന്താണ്, ബെനിഫിറ്റ്സ് എന്താണ്, എന്തൊക്കെ ക്രൈസിസ് ആണ്, ഗ്ലോബൽ ക്രൈസിസ് ആണ് നമ്മൾ നേരിട്ടുകൊണ്ടിരിക്കുന്നത് ഈ പാലിയേറ്റീവ് കെയറിൽ എന്നെല്ലാം ഉള്ള ക്ലാസ് സ്റ്റെല്ല മാം നന്നായി പറഞ്ഞു തന്നു. അതുപോലെ തന്നെ നമ്മുടെ സെക്കൻഡ് ക്ലാസ് ട്രാൻസ്കൾച്ചറൽ നഴ്സിംഗ് ആയിരുന്നു അല്ലേ? അതിനകത്ത് വന്നിട്ട് ഡിഫറെൻറ്റ് കൾച്ചർ ആൻഡ് ബിലീഫ് ഓഫ് പേഷ്യൻറ്റ്, എങ്ങനെയാണ് അവരെ ഹാൻഡിൽ ചെയ്യേണ്ടത്, അതുപോലെ തന്നെ ട്രാൻസ്കൾച്ചറൽ ചലഞ്ചസ് എന്തൊക്കെയായിരുന്നു, ബിഫോർ ആക്സസ് ആൻഡ് ആഫ്റ്റർ ആക്സസ് എങ്ങനെയാണ് പാലിയേറ്റീവ് കെയറിൻ്റെ ചേഞ്ചസ് വരുന്നത് എന്നെല്ലാം തന്നെ നല്ല രീതിയിൽ നമ്മൾക്ക് നന്നായിട്ട് ട്രെയിനിങ് പ്രോഗ്രാം നടത്തി തന്നു. അതുപോലെ തന്നെ സ്റ്റെല്ല മാമിൻ്റെ നെക്സ്റ്റ് ക്ലാസ് പാലിയേറ്റീവ് കെയർ പ്രാക്ടീസസ് നീഡ്സ് എന്താണ് അതിൽ പറഞ്ഞത്? ഹെഡ് ആൻഡ് ഹാൻഡ്സ്. ഈ 3 തിങ്സും കൂടെ ഉണ്ടെങ്കിൽ മാത്രമേ നമ്മളുടെ പ്രാക്ടീസസും നോളജും അതുപോലെ തന്നെ ഫീലിങ്സും എല്ലാം കൂടെ ഒന്നിച്ച് വന്നാൽ മാത്രമേ പാലിയേറ്റീവ് കെയർ എഫക്റ്റീവ് ആവത്തുള്ളൂ എന്ന് നമ്മളെ ഓർമ്മപ്പെടുത്തി. അതുപോലെ തന്നെ ഡോക്ടർ PT തമ്പി സാറിൻ്റെ വേരിയസ് പെയിൻ മാനേജ്മെൻറ്റ് എങ്ങനെയാണെന്നുള്ളതും അതിൻ്റെ ഡോസ് കൺട്രോള്, ഡിഫറെൻറ്റ് പേഷ്യൻസിന് എങ്ങനെയാണ് പെയിൻ മാനേജ് ചെയ്യേണ്ടത്, ഫാർമക്കോളജിക്കൽ ആൻഡ് നോൺ ഫാർമക്കോളജിക്കൽ എങ്ങനെയാണെന്നുള്ള എല്ലാം കാര്യങ്ങൾ നമ്മൾക്ക് അവയർനെസ് തന്നു. അതുപോലെ തന്നെ ലവ്ലി മാമിൻ്റെ ഇന്നൊവേഷൻ ഇൻ പാലിയേറ്റീവ് കെയർ, നമ്മുടെ ന്യൂ ടെക്നോളജി ഉപയോഗിച്ച് AI ഉപയോഗിച്ച് അല്ലെങ്കിൽ ടെലിപ്പതി ഉപയോഗിച്ച് എങ്ങനെയാണ് പാലിയേറ്റീവ് കെയറിനെ മാനേജ് ചെയ്യേണ്ടതെന്നുള്ളത് പറഞ്ഞു തന്നു. അതുപോലെ തന്നെ സ്റ്റെല്ല മാമിൻ്റെ എത്തിക്കൽ സ്പെഷ്യൽ കമ്മ്യൂണിക്കേഷൻ എങ്ങനെയാണ് എഫക്റ്റീവായിട്ട് പേഷ്യനോട് സംസാരിക്കേണ്ടത്, ഇപ്പോൾ ഹോം കെയർ ആണെങ്കിലും ഹോസ്പിറ്റൽ പേഷ്യനോടാണെങ്കിലും എങ്ങനെ എഫക്റ്റീവായിട്ട് കമ്മ്യൂണിക്കേറ്റ് ചെയ്യാം, ഡോണ്ട് ടെൽ ലൈ ടു ദ പേഷ്യൻ്റ് അല്ലേ എന്നുള്ളത് നമ്മളെ ഓർമ്മപ്പെടുത്തി. അതുപോലെ തന്നെ എത്തിക്കൽ മൂവ്മെൻറ്റിനെ പറ്റി ലവ്ലി മാം ഒരു ക്ലാസ് എടുത്തു. DNRും ലിവിങ് വില്ലൊക്കെ എങ്ങനെയാണ് പേഷ്യൻ്റെ ആ പ്രിഫറൻസ് വെച്ച് എങ്ങനെയാണ് നഴ്സിംഗ് കെയർ പ്ലാൻ തയ്യാറാക്കേണ്ടതെന്നും അവരുടെ കൺസേൺ എങ്ങനെയാണ് ട്രീറ്റ്മെൻറ്റിൽ ഉൾപ്പെടുത്തേണ്ടതെന്നും എല്ലാം നമ്മൾക്ക് മനസ്സിലാക്കി തന്നു. അതുപോലെ തന്നെ ലാസ്റ്റ് ക്ലാസ് സ്റ്റെല്ല മാമിൻ്റെ ഹൗ വി ക്യാൻ അപ്ലൈ തിയറി ടു പ്രാക്ടീസ്, ഹെഡ് ടു ഫുഡ് അസസ് ചെയ്ത് നമ്മുടെ പാലിയേറ്റീവ് കെയറിൽ എങ്ങനെയാണ് സിംറ്റം മാനേജ്മെൻറ്റ് ചെയ്യേണ്ടത്, ഫിസിക്കൽ, സൈക്കോളജിക്കൽ, സോഷ്യോളജിക്കൽ ആൻഡ് സ്പിരിച്വൽ മാനേജ്മെൻറ്റ് എങ്ങനെയാണ് കൊടുക്കേണ്ടതെന്നുള്ളത് നമ്മളെ ഓർമ്മപ്പെടുത്തി. ഇങ്ങനെ എല്ലാം കൊണ്ടും നല്ല ഒരു ക്ലാസ് ആയിരുന്നു. 2 days നല്ല ഒരു ട്രെയിനിങ് പ്രോഗ്രാം ആയിരുന്നു. എല്ലാവരും തന്നെ കൂടുതൽ അവയർനെസ് പാലിയേറ്റീവ് കെയറിൽ എടുക്കാനും അതിൽ കൂടുതൽ തലങ്ങളിലേക്ക് ആക്സസ് ചെയ്യുവാനും ഈ പാലിയേറ്റീവ് കോളേജ് ഓഫ് നഴ്സിംഗ് ചെയ്ത പാലിയേറ്റീവ് കെയർ കൊണ്ട് തന്നെ നമുക്ക് സാധിക്കട്ടെ എന്ന് ആശംസിക്കുന്നു. അതുപോലെ തന്നെ നമ്മുടെ മറിയാമ്മ സിസ്റ്റർ ഇവിടുത്തെ ഒരു അസറ്റാണ്. എനിക്ക് നേരത്തെ അറിയാം പാലിയേറ്റീവ് കെയറിൽ എല്ലാം നന്നായിട്ട് കെയറും കാര്യങ്ങളും എല്ലാം ചെയ്യുന്നുണ്ട്. മറിയാമ്മ സിസ്റ്ററിനെ പ്രത്യേകം അപ്രീഷിയേറ്റ് ചെയ്യുന്നു. കോളേജ് ഓഫ് നഴ്സിംഗ് ചെയ്ത എന്തുകൊണ്ട് ഈ ട്രെയിനിങ് നല്ലൊരു ഫ്രൂട്ട്ഫുള്ളായിരുന്നു. പാർട്ടിസിപ്പേറ്റ് ചെയ്ത എല്ലാവർക്കും തന്നെ നല്ല ആശംസകൾ ആശംസിക്കുന്നു.
Thank you, ma'am. Gratitude makes a day complete. We have reached the concluding part of our palliative care workshop. It's time to express our gratitude. We are pleased to invite Mrs. Sylvie Matthew, HOD, Medical Surgical Nursing Department, to deliver the vote of thanks.
A very good afternoon to one and all present here. As we come to the close of this international workshop on palliative care, Florian Soins 3, Embracing the End with Dignity, it is my privilege and honor to propose the final vote of thanks. First and foremost, we thank the Almighty God for blessings which He provided these 2 days with fruitful discussions, enriching sessions, and a spirit of learning and compassion. Our deepest gratitude goes to Reverend Father Dr. Biju Verghese, CEO, Pushpagiri Medical College Hospital, for his vision and blessings that constantly guide us. We extend our sincere thanks to our director, Reverend Father Matthew Puthinparel, whose leadership, vision, and unwavering commitment towards the institution have been a source of inspiration. Father really helped us in every aspect of our journey. We are grateful to our principal, Professor Vinita Jacob, for her encouragement and motivation. Without her guidance, this workshop would not have been a success. I would also like to thank our vice principals, Mrs. Ranjini Devi and Mrs. Mary Jyoti OSS, for their prayers and support throughout this event. A special thanks to the teachers of Medical Surgical Nursing Department, whose hard work and commitment made this workshop possible. Your tireless efforts in planning, coordinating, and ensuring everything ran smoothly did not go unnoticed, of course. Your contributions to the success of this event are truly, truly appreciated. A very special word of thanks to Dr. PT Thambi, Ms. Ann Jomi, Ms. Anu Savio. Your insightful sessions, expertise, and compassionate sharing having left a lasting impact on. A warm appreciation to all the participants and faculties of Pushpagiri College of Nursing for your active involvement and interactions and enthusiasm. Kudos to our 4th SEM BSc Nursing students. You all were phenomenal in ensuring that everything ran smoothly. From registration to assisting the speakers and helping the participants, your dedication and support have been truly outstanding. Thank you so much. Special thanks to our non-teaching staff, Sony sir for the technical support, dedicated live streaming team, especially Alex sir, for their seamless broadcasting, allowing us to connect with the participants who could not join us physically. Pushpagiri Central Kitchen Padayam for the delicious feast they provided, Asha Chechi and housekeeping Chechis for their support. Last but not the least, our sponsors, Solar Base Energy Partners. With gratitude in my heart and head held high, I thank each one of you once again, wishing you all a wonderful evening. Thank you and God bless.
Thank you, ma'am. As we come to the close of this conference on palliative care, this will be highlighting the urgent need of strength of palliative care services through education, innovation, and policy support. Let us continue this beyond today and work collectively to ensure that palliative care becomes an integral part of our healthcare system.
Now, I invite everyone to please stand and join our college choir in honoring the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जाहे तव शुभ आशीष मागे गाहे तव जय गादा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Once again, thank you all and have a good evening.